duration of immunotherapy is really a hot topic now. We give immunotherapy for most of our patients with non-addicted non-small cell lung cancer first line, and most of the drugs has been approved with a two-year scheme, meaning that you stop after 2 years, but all the studies show that after 2 years, when you stop, half of the patients will relapse. And the big question is, more immuno is better. So we have a few studies in terms of prospective studies. We have the nivolumab studies, CheckMate 1, 5, 3, where nivolumab was given 1 year or more, but the methodology is quite poor because it was not the primary objective. And the only benefit to go on with immunotherapy in those patients with partial response or complete response. We use 2 years, though. We cannot have a big take-home message from this study. There was one randomized study, French study, called DICIPLE, with ipilimumab and nivolumab, comparing 6 months or more. But unfortunately, it was only 60 patients randomized because the trial was stopped because ipi-nivo is not a standard of care in Europe. But it showed that it's not detrimental, apparently, to stop at 6 months with less toxicity. But again, EP is on board. There are ongoing studies that test 6 months versus more. In the early stages, we can look at the consolidation therapy after chemorad. Two main studies, one with durvalumab that we use, and one with one study called Gemstone, in which 2 years of a PD-1 blocker was given compared to a placebo. If you look at the curve, no real differences between the two studies. So totally an open field. I hope we will have biomarker to decide in which patients we can stop. In melanoma patients, they can stop sometime after 6 months or 1 year. When they have a complete response, what happened in around 30 to 40% of the cases. In lung cancer, we don't have so much complete responses, so we might need to use circulating tumor DNA to guide us on who are the patients that really, where you can really stop the immunotherapy safely.